Hey guys, today we'll be talking about the other kind of cellulitis known as the Ludwig's angina. So, Ludwig is the name of a general physician who discovered the severity of the disease in 1836. Whereas angina is a Latin word, it means strangle or choking. And this term refers to the clinical features associated with Ludwig's angina that we will see in the video. So, Ludwig's angina is a life-threatening cellulitis. It involves the floor of the mouth and neck. The infection usually originates from the lower molars in 70% of the cases. So, some of the causative factors for Ludwig's angina are: the main one is the infection of the posterior teeth, or it could be peritonsillar or parapharyngeal abscess. It could be due to tongue piercing, oral lacerations, fractures of the mandible, and Submandibular Sialadenitis. This is a stone in the submandibular gland. Now, to understand the disease process, let's go through the anatomy. The mylohyoid muscle divides the submandibular space. Over here is the mylohyoid muscle, and above it is the sublingual gland. Just above the mylohyoid muscle, we have the sublingual space next to the sublingual gland. And just below the mylohyoid muscle is the submaxillary space. Now, let's try to understand the pathophysiology, how this disease process occurs. First of all, as we know that the infection is going to originate from the teeth, and usually the lower second and third molars are involved. Now, why is that? Well, the most common reason for that is that the roots of the second and the third mandibular molars, they lie below the mylohyoid line, as we can see in this picture. Now, when this happens, the submandibular space is more prone to getting the infection as compared to the rest of the spaces. So what happens next is that usually the bacteria involved in Ludwig's angina is the Streptococcus species. But there are some other bacteria like the Staphylococcus, Fusobacterium, and the Bacteroides species. Now, the infection initiates in the subgingival pocket, and it spreads to the musculature of the floor of the mouth. Eventually, this enters the sublingual space. Now, as we all know that the lingual alveolar bone of the tooth socket is much more thinner as compared to the buccal aspect. So, this means that the infection is going to easily spread through the lingual aspect of the tooth socket. And when that happens, it enters the submandibular space. Now, let's try to understand this whole disease process diagrammatically. Now, this is the sublingual space, and just below it is the mylohyoid muscle, and below and inferior to the mylohyoid muscle is the submandibular space. Just next to that is the submental space. Now, first of all, like we discussed before, the infection is going to originate from the molars. Once that happens, it enters the sublingual space, and crossing the mylohyoid muscle, the musculature, it then enters the submandibular space and eventually the submental space. As the disease progresses, the infection also travels contralaterally to the other side and enters the sublingual space, and the same pathway follows. Now, let's look at some of the risk factors which increase the chance of an individual getting infected from Ludwig's angina. Dental caries or a recent dental treatment. In both these cases, a source of infection is created which extends periapically. In case of a recent dental treatment, instrumentation at the level of the gingiva may force some of the bacteria to enter the gingival pocket, and that travels periapically. Other causes include diabetes mellitus. So, in case a person has diabetes mellitus, they suffer from xerostomia. This results in an increased risk of caries. So basically, when the saliva production is less, the mouth stays dry. This increases the risk of caries. High blood sugar levels. So what high blood sugar levels does is that the white blood cells, which are the infection-fighting cells of the body, they slow down and they reach slowly to the site of infection. And when they eventually reach the site of infection, they're unable to stay at the infected area and eventually kill the microorganisms. Oral malignancy or poor oral hygiene. In poor oral hygiene, the mouth is automatically more susceptible to caries. Malnutrition. Now, there are two main reasons why malnutrition is a risk factor for Ludwig's angina. First of all, if the person suffers from malnutrition, the serum thymic factor is usually less. That causes a reduction in the mature T lymphocytes. Now, when this happens, there is a reduced cell-mediated immunity. The other reason is that the CD4 ratio to CD8 ratio T lymphocyte cells decrease. So this causes a decrease in the number of antibody-producing cells, which also leads to a decrease in the immunoglobulin secretion. Immunocompromised state, for example in AIDS or HIV, and organ transplantation. In both these cases, there is reduced immunity for the body to fight off any infection, even if it's a simple infection. Now, let's look at some of the clinical features. First of all, there's going to be swelling of the neck, which often extends to the clavicles. If the sublingual space is involved, there is a phenomena which is known as woody tongue. Now, what is woody tongue? In this, there is elevation, posterior enlargement, and protrusion of the tongue. If the submandibular space is involved, then there is going to be enlargement and tenderness of the neck above the level of the hyoid bone. Over here in this picture, we can see that this is the hyoid bone, so there is going to be enlargement, swelling, and tenderness above this area. Now, this is known as bull's neck. I've added some pictures for us to remember all of these names. Eventually, this infection is going to spread to the other side as well, involving whole of the neck. So there is going to be pain in the neck and the floor of the mouth. The patient will not be able to move their neck properly, and there may even be drooling and sore throat. There is also which is something known as dysphagia. It means swallowing difficulty. Because there is swelling of the neck, the patient may have difficulty swallowing. Dysarthria. This is motor speech disorder, or slurring of the speech may occur. And lastly, something which is known as dysphonia may also occur. In this, the patient will have trouble with the voice. Pitch or the quality of the voice may have some changes in it. Now, this is a picture of the oropharynx. Over here is the larynx, which is also known as the voice box. Just above it is the pharyngeal area. Now, if this pharyngeal area is involved laterally, then there's going to be laryngeal edema. Now, what happens then is there is going to be respiratory difficulty and obstruction. Some of the other respiratory symptoms include tachypnea, which means rapid breathing. Dyspnea may also occur. This is basically shortness of breath. And something which is known as stridor. Now, what is stridor? Stridor is basically a high-pitched sound. It usually occurs when we inhale, and it is associated with an obstruction of the upper airways. Now, I've added some more information here so we can differentiate between stridor and wheezing. Now, wheezing does not occur in Ludwig's angina. Wheezing usually occurs in asthma or bronchial diseases. So, wheezing is a whistle-like sound, and it happens usually on expiration, when we breathe air out. And it usually occurs due to the obstruction of the lower airways. Now, some of the systemic symptoms include fever, chills, and an increase in the heart rate, which is known as tachycardia. The patient may also experience restlessness, and there might be leukocytosis, which means an increased level of cells on investigations. Now, how are we going to manage Ludwig's angina? There are two basic principles. First of all, the maintenance of airway, and the second is the resolution of infection. So for airway maintenance, there are a few options. we can use flexible fiber optic nasal intubation. It is the most favored method out of all of them. Others include orotracheal intubation, tracheostomy, and cricothyrotomy. It may be difficult to do orotracheal intubation because there is presence of trismus, meaning a locked jaw and a swollen neck. Cricothyrotomy is usually preferred because it lowers the risk of spreading the infection to the mediastinum. Now, I've added a diagram here so we can understand all these procedures a little better. Over here is the thyroid cartilage. Just below it is the cricothyroid ligament. Then we have the cricoid cartilage, and just below it is the trachea. So there are 2 points. There is point A and point B, one on the cricothyroid ligament and the other on the trachea. The point A is where cricothyrotomy is done, and point B is where tracheostomy is done. So point A is usually more preferred as compared to point B. Now, the next step is the resolution of infection. So what we need to do first is eliminate the source of infection by extracting the infected tooth and draining out any pus which is associated with it. Secondly, we're going to prescribe intravenous antibiotics. Penicillin is combined with clindamycin or metronidazole. Clindamycin is for methicillin-resistant Staphylococcus aureus coverage, and metronidazole is for anaerobic coverage. Now, the patient is also prescribed intravenous corticosteroids. This helps in reducing the swelling and helps to augment the antibiotic penetration. But if all of this medical intervention fails, then surgical decompression is done. Incision and drainage is done, which provides the patient some relief of the airway obstruction. Over here, we can see that this is an abscess which is filled with pus and inflammatory cells. First, an incision is made into an abscess filled with pus and inflammatory cells. This is known as incision and drainage. Then, some dressing is placed inside the empty area, which helps it to heal faster. So guys, this was everything that you need to know about Ludwig's angina. Keep watching my videos for more lectures. Thank you.